Welcome to the NEET PG Core Revision series in Pharmacology, where I will be taking up the important topics for the upcoming NEET PG examination. So today we are going to study drugs for osteoporosis and anti-thyroid drugs. So first let's do the drugs for osteoporosis, and we need to know that what drugs that we are using in osteoporosis work on the osteoclasts or what work on the osteoblasts. So there are certain drugs which will inhibit the resorption. That is why, because they are going to inhibit the osteoclasts, which are going to cause the resorption, and because they inhibit the osteoclasts and inhibit the resorption, they lead to hypocalcemia, because that calcium is no longer withdrawn from the bone and it enters into the blood vessels. It doesn't enter into the blood. That's how. Okay. So which are these main drugs here? The first most important drug, that is your bisphosphonates. Bisphosphonates. Then we have selective estrogen receptor modulators like raloxifene. Then we have calcitonin, then INI-CET, and a monoclonal antibody, denosumab. Then we have drugs, the anabolic drugs, which are going to stimulate the formation of the bone by promoting the osteoblast. So very important drug here is teriparatide. Then we have calcium, vitamin D, and fluorides. Certain drugs to they are going to do both the functions. That is, they are going to inhibit the osteoclast and they are going to promote the osteoblasts. So here we have strontium granulate and another monoclonal antibody, romosozumab. It inhibits sclerostin, and because it inhibits sclerostin, they are going to have dual action of stimulating the osteoblasts and inhibiting the osteoclasts, right? So this is how we classify these drugs. So moving on to the MCQ which was asked in the previous years, which of the following is considered as the first line treatment for post-menopausal osteoporosis? Estrogen, bisphosphonates, loxapine, combined oral contraceptives. So whatever the cause is of osteoporosis, the first drug or drug of choice is always your bisphosphonate. So they remain the most important drugs that you should be knowing out of this particular topic. So moving on to what are bisphosphonates. So bisphosphonates, these drugs, we have actually they are older generation, the first generation, and then as we go down, they are the new third generation. So first to new third generations, the difference is in the potency of the drug. So the first generation ones, they were less potent, and as we move on higher up in the generations, the potency is going to go up. So we can say it is a zoledronate. It's a very potent drug. So etidronate, tilodronate, they belong to the first generation, but they are no longer used now because now better drugs are available. Okay. Then we have alendronate, ibandronate, pamidronate, risidronate, zoledronate. So all have dronates at towards the end. So few drugs, they are given by the oral route. So remember mnemonic air. So air, we breathe air. So oral route air. A is your alendronate, I is abandronate, and R is risidronate. Then for the IV route, you can remember zip, right? Zip, zoledronate, ibandronate. So ibandronate is given by both oral as well as the IV route, and P is pamidronate. So remember oral and IV drugs. Now zoledronate is a very, very potent drug, and you can give IV infusion only once a year. So it will accumulate in the bone and gradually it produces its effect. So that is how potent this drug is. Okay. Now, important, what is the mechanism of action of these drugs? So they block the farnesyl pyrophosphate synthase. So let's do actually what it does is, so we have, this is the bone here, and this is your osteoclast, which has the ruffled surface, and these are multinucleate cells, right? So what does bisphosphonate do? Bisphosphonate drugs, bisphosphonates, they bind to the hydroxy apatite of bone, right? So somewhere in the bone, these drugs will be there. They bind to this. And osteoclasts, they are going to take up this bisphosphonate while they are doing their action on the bone. So osteoclast take them up through the bone. Okay. So when the bisphosphonate enters into the osteoclast, what it does is, number one, it is going to disrupt the cytoskeleton of the osteoclast, and it is going to cause the apoptosis. It is going to cause or kill these or destroy these cells, apoptosis. Number two, they are going to damage the ruffled border. The ruffled border. So this ruffled border is actually responsible for causing the osteoclastic activity or causing the resorption of the bone. So they will damage this ruffled border. So when this ruffled border is damaged, they are not able to actually take out or do the resorptive process. This is how they are going to decrease the resorption. Number three, this is also going to inhibit the cholesterol synthesis. Cholesterol synthesis. Why? Because they block the mevalonate pathway. And this is important for the, for the work or the functioning of the osteoclast. So these are the three main ways by which they act. So they disrupt the cytoskeleton, cause apoptosis, they damage the ruffle surface, and they are going to block the mevalonate pathway. So where are these bisphosphonates mainly indicated? So they are drug of choice for any kind of osteoporosis. So whether it is postmenopausal or it is steroid induced osteoporosis, any type, they are used. Then they are given in drug of choice in Paget's disease and in case of hypercalcemia of malignancy, because they cause hypocalcemia. So they can be given in hypercalcemia malignancy. So for post-menopausal induced or steroid-induced osteoporosis, you give them by the oral route. For these two, you give them by the intravenous route. Okay. Now moving on to the important adverse effects of these drugs. So these are toxic drugs in the sense you have to very carefully explain to the patient that they have a tendency to cause erosive gastritis or esophagitis. So what to do is that patients should take them. So this is especially true with the oral drugs. So patients should take them empty stomach with a glass of water. And patient should not lie down for at least 30 minutes after taking the drug, because if it lies down, then the drug can go back into the esophagus and cause irritation. That's why. So this is a very, very important instruction to be given to the patient. Then it can cause renal toxicity, especially with highly potent drugs like zoledronate, more common. Osteonecrosis of jaw. Again, it is seen with very, very potent drugs like zoledronate. Stress fractures or chalk stick fractures of femur. Why? because when you give these drugs for long period of time, they are going to cause decrease in the bone resorption, right? So you know that for new bone, or the, for the, what you call that, remodeling of the bone, it is important that resorption takes place and then new bone is formed by the osteoblast. So both the functions are equally important. But now what is happening is they're not leading to the resorption of the bone. So that bone remodeling, it does not take place. The bone turnover is not taking place. So the bones become very brittle and easy to break. So that's why they are called as stress fractures. So because of the decrease in the bone resorption, there is a decrease in the bone turnover as well. Okay. So because of that, there is stress fractures. So mostly this occurs on long-term use of bisphosphonates. Osteomalacia, because of the etidronate, it is more prevalent. That's why it is no longer used, not used anymore because of this problem. Now remember that these bisphosphonates should not be given for more than 5 years. So we can write here, not given for more than 5 years, because the side effects, the risk of adverse effects are going to increase because of this. Okay, now the next drug, important drug we have, is the teriparatide and abaloparatide. So both of these, they are anabolic drugs. They are going to increase the formation of the bone. So they are anabolic in nature, but they're only used for 2 years, right? Not more than 2 years. So main role, or they are the drug of choice, their major role is in case of bisphosphonate induced fractures, because they will help in increasing the formation of the bone. And if patient cannot tolerate bisphosphonate, then we give it in case of the osteoporosis, but we prefer to give bisphosphonates first. So what is this? Teriparatide is a recombinant parathyroid hormone. Parathyroid hormone, if you give it, then they are going to cause increase in the resorption. But recombinant parathyroid hormone, it is leading to bone formation. It consists of the amino acids 1 to 34 from the parathyroid hormone. Whenever parathyroid hormone is given in low dose and in intermittent fashion, it always leads to increase in the formation of the bone. But whenever you give this drug in continuous fashion, then it is going to cause increase in resorption. So here we are giving it intermittently also, and the first 34 amino acids only are taken from the parathyroid hormone. Major adverse effects is they can lead to, because they are going to cause increase in the bone formation, they can lead to nephrolithiasis. Then it can cause hypercalcemia, okay, and osteosarcoma. This is a very, very important drawback. Cancer, osteosarcoma. So there is growth in the bone. You can see this is osteosarcoma. That's why we cannot recommend for this to be given for more than 2 years. Contraindication, if already there is hypercalcemia, right, and in case of Paget's disease. In both these conditions, we cannot give them. Other drugs that we have is cinacalcet, and in cinacalcet, basically what it does, it acts on the calcium sensing receptor. This is present on the parathyroid gland. So this is, let's say, your parathyroid gland, and there is a calcium sensing receptor present over here, and it is basically used to sense the level of calcium in the blood, right? So it senses the level of calcium in the blood, and when it senses the level of calcium in the blood, it will trigger the release of parathyroid hormone, because parathyroid hormone ultimately it's going to cause resorption. So if there is hypocalcemia, then it will trigger the release of parathyroid hormone. But here we do not want resorption basically. So what it does is the cinacalcet, it acts on this receptor. This is a calcium sensing receptor, and it will tell it that the calcium levels are fine. You don't need to go anywhere. So it is going to inhibit the release of parathyroid hormone. Because of this, there is going to be decrease in the bone resorption. Remember, parathyroid hormone, the main aim is to increase the serum calcium levels. So, if it is causing resorption of bone, then only it can increase the serum calcium levels. So, here we are going to prevent this. The major adverse effects, the most common here actually with this is diarrhea. Now, because it causes decrease in the bone resorption, so calcium will not be there in the blood, so there will be hypocalcemia. So, there can be tetany-like features, paresthesia, etc. also alongside. Denosumab. Now, denosumab, what is the role? So, this is the osteoclast precursor, and on the osteoclast precursor, we have a receptor which is called as RANK. Now, for this receptor, there is a ligand as well which needs to bind. So, this is called as rank ligand. Rank ligand. So, when rank ligand binds to this rank receptor, it leads to activation of this osteoclast precursor and it leads to formation of the osteoclast. So, what denosumab does is, denosumab is going to inhibit, it is going to bind to rank L and it is going to inhibit its attachment to rank ligand. So, denosumab, it binds to rank L and therefore prevents the activation of osteoclast precursor because it will not bind to the rank receptor. That's the role of this particular drug. Now, this drug is also used in these cases whenever it is, serious cases of osteoporosis as such. And the major adverse effects are that it can again cause fractures of the femur, stress fractures, and it can also lead to osteonecrosis of the jaw. Okay. Calcitonin. Now, calcitonin, it is one of the fastest acting drug out of the lot, but it is not used. Now, calcitonin, the main role of calcitonin is to inhibit the bone resorption. That's the main role, and it is used in Paget's disease. Right? So, adverse effect can cause nausea, flu-like symptoms, etc. So, these are the important drugs for the osteoporosis. Moving on to the next topic is your anti-thyroid drugs. So, these drugs are given in cases of hyperthyroidism. So, we have these various thyroid inhibitors. The first group of drugs are the drugs inhibiting the trapping of the iodide, and they inhibit a special type of transporter which is sodium iodide symporter. These are thiocyanates and perchlorates. So, remember here we have, this is the thyroid follicular cell, and thyroid hormones, they are formed in the follicular cells in the colloid here. So, first we need to take up the iodine from the diet. So, this iodine from the diet is trapped inside the thyroid follicle with the help of the symporter, which is the NIS, right. So, this is the NIS symporter, which is sodium ions and the iodide ions, they are moving inside. So, this step is blocked by the first group of drug, right, that is the trapping. Now, these drugs are very toxic drugs and they are not used. Second, drugs. Now, after the iodide has come inside, it needs to enter into the colloid, and in the colloid there is an enzyme called as TPO. This TPO is thyroid peroxidase. This is important because it causes iodination, coupling, oxidation of these iodines, and basically it leads to formation. So, this is, we have the thyroglobulin molecule, and this thyroglobulin molecule consists of tyrosine residues where these iodides, this iodine is going to bind, right. So, it is inhibited by TPO because this is now going to lead to the formation of T3 and T4, right? And when this T3 and T4 is formed, so these three steps are very, very important performed by the TPO. Second group of drugs inhibits this TPO, propylthiouracil, methimazole, carbimazole. So it is going to inhibit the synthesis of the newer hormones, but the original ones which are present in the body, they are not going to be affected. Then after these thyroid hormones are formed, they go inside the follicular cell again, and then they are released into the circulation. So T4 is more than T3, and ultimately T4 also gets converted to T3, and T3 is released as such. So this is the point which is called as the release. So the third group is the drug which is going to inhibit the release of these thyroid hormones. These are your iodides, sodium iodide, potassium iodide, glucose, iodine. Then we have drugs which are going to destroy the thyroid gland. So you give these drugs, radioactive iodine, it is going to destroy this thyroid tissue as such. Then drugs which are going to inhibit the peripheral conversion. What is the peripheral conversion step here? If you see this step of T4 being converted into T3. Now why is this important? Because this T3 is actually the active form. T4 is not the active form. T3 is the active form which is going to produce all the actions of thyroid hormones. So released T4 is also released, rather it is released more as compared to T3, but actually actions performed by T3, right? So this is the important point here. So this is called as the peripheral conversion, and this is very, very important step here. So there are drugs to inhibit the peripheral conversion: propylthiouracil, propranolol, amiodarone, even we have prednisolone like steroids. They can also block this step, right? So these are the various drugs inhibiting. Now let's do some important points here. So which is a drug of choice for hyperthyroidism? So out of all these drugs, the drug of choice for hyperthyroidism are the second group, the ones inhibiting the TPO. They're also called as the anti-thyroid drugs. And out of that, we have carbimazole and methimazole. This is the drug of choice. Propylthiouracil on long-term use, it can lead to hepatotoxicity. Therefore, it is not recommended for long-term use. Right? So long term, we have these two drugs. Then important thing is about iodides. Now iodides, they like sodium and potassium iodide, so they are given preoperatively in case of hyperthyroidism, so that we bring down the thyroid levels, that is before surgery. And what they do, they make the gland firm and less vascular. So what is, they cause shrinkage of the gland, so that it's easy to perform the surgery. Less bleeding is going to be there. Less complications are going to be there. Radioactive iodine, this is an alternative to surgery, right? So it is used in elderly because they may not be fit for surgery. So it is an alternative to surgery, right? So one of the basic issues, they can cause irreversible. The major side effect is irreversible hypothyroidism. The other drugs are reversible. You stop giving the drug, the effects are reversed. But they cause irreversible hypothyroidism. So they are also used in thyroid cancers. But this is contraindicated in pregnancy. Radioactive iodine. Now, some important one-liners here. Anti-thyroid drug of choice in thyroid storm. Thyroid storm is an emergency where there is increased levels of thyroid hormones, and what we worried about mainly is because they can cause tachyarrhythmias. They can ventricular fibrillation can occur in these patients, because what do thyroid hormones do? They sensitize the catecholamine receptors to the effect of catecholamines. So especially in the heart, your beta receptors are there. So more effect of the catecholamines on that. So there can be increase in the heart rate leading to dangerous ventricular fibrillation. That's why we are very, very worried about that. So first thing what you do, the antithyroid drug of choice in the thyroid storm, antithyroid. Remember, if it is antithyroid drug of choice, then that is propylthiouracil. Why? Because it prevents the conversion of T4 to T3. So T4 to T3 is blocked. That is why we are worried about this. The action of on the thyroid peroxidase enzyme, which it does, it is not a quick action. It will take some time to produce the effect because the hormones are already present in the body. They are going to do the effect. So it won't be effective against the already produced in the hormones. Only it is going to inhibit the synthesis of the newer hormone. Then, if the question is asked the drug of choice in thyroid storm, then your answer should be a beta blocker, propranolol. Because propranolol also inhibits the T4 conversion to T3, and it will also have a sympatholytic effect. So on the beta 1 receptors, it will block those receptors and it will not allow the arrhythmias to occur. It's a very, very important point here. So drug of choice for hyperthyroidism in first trimester. Remember, first trimester, we cannot use carbimazole, methimazole because they have a teratogenic effect. So in first trimester, your drug of choice is propylthiouracil. Then in second and third trimester, you can go back to carbimazole or methimazole. Okay. So what are the teratogenic effects of carbimazole and methimazole? Remember, mnemonic called as FACE. FACE is F, fetal hypothyroidism. A, this is called as aplasia cutis. This is choanal atresia, esophageal atresia. Aplasia cutis means missing skin here. So these are the teratogenic effects seen with the carbimazole, methimazole. That's why they're not used in the first trimester. Then we have drugs inhibiting the peripheral conversion that we've already done that in the classification. That is again to revise propylthiouracil, propranolol. Another P is prednisolone. Then we have a drug antiarrhythmic, amiodarone. So all these drugs are going to inhibit the peripheral conversion. So what are the drugs which are used for thyroid storm? So drugs which are used for thyroid storm, first is propranolol. Then we can give propylthiouracil. We can give iodides, right? Because they all prevent the peripheral conversion of this. Then we give prednisolone. And in case arrhythmia is not handled properly by propranolol, you can add a CCB like diltiazem. Okay. Now, so this was about the hyperthyroid. So what about if patient has hypothyroidism, which is more common? In the hypothyroidism, we have two hormones. One is T4 and the other one is T3. T4 is levothyroxine. So this is preferred for daily use. Why? Because it has a long half-life. So it has a more sustained action. And it has less chance of atrial fibrillation or arrhythmias. Because T3 is the active form, very quick or short acting, it has more chance to cause the atrial fibrillation. So this drug, it is given by oral route, right? That is levothyroxine, and as an emergency like in mixed edema, we can also give it by the IV route, especially mixed edema, coma. Not regularly we can give it by oral route, but coma, emergency, we give it by the IV route. Now T3 can also be given by the IV route only in emergency like mixed edema, coma. not for regular use, because there is a risk of atrial fibrillation. That is the most important thing that we need to be worried about here. So T4 is preferred, right? And another important thing, because they have nuclear receptors, so these are nuclear receptors, the effect will not be seen immediately. So there we need 4 to 6 weeks for the effects to be shown. That is very important for these drugs. Alright, so with this we come to the end of this topic, drugs for osteoporosis and anti-thyroid drugs.